Here is our team. First of all, we really would like to thank Robert Wood Johnson Foundation and the Inquiry Project, first of all, for funding us and bringing even presenteeism to the table in the national forefront. So we are very, very grateful. Here is our research team, and I'm here with Sat, and Chris Room, our economist, is at UNC Greensboro, and he is in transition. He has accepted a job at UVA, so this semester he's at both places. So for those of you I know that know Chris, in January he will be fully at UVA. He's starting a new program in health policy at the graduate level. Our research questions, we have a mixed methods approach, and our first question was to determine the prevalence and extent of presenteeism, which is a decrease in productivity due to a health problem. And we specifically looked at musculoskeletal pain and or depression in nurses and how that impacts productivity, examining the relationship among individual characteristics, workplace characteristics, presenteeism, and perceived quality of care, and then to estimate the possible costs of presenteeism due to pain and or depression. Why is this important? First of all, there's been a large body of research that has shown that worker health, especially pain and depression, impact productivity, errors, and safety in general large cohort studies of workers. We know that nurses have very high rates of musculoskeletal pain and are under increasing job stress and mental strain. What was not known is how nurses' health impacts patient safety and quality of care at a time of increasing costs, increasing errors, and at a time of more and more cost concerns. And the first part of the study was a large survey design correlational study where we sent 2,500 surveys out. We received 1,171 usable surveys for a response rate of 47%, and Sat will now present our findings.
Well, thank you, Susan, for giving me the easy job. Let me confess, first of all, that I know very little about healthcare. This is a very different kind of audience for me. I'm a math person who knows a little bit of statistics. And let me try to help out here a little bit. Well, here are some of the characteristics. We collected a lot of information. But this is what actually Susan chose to put here. Average age, it's very similar to what it is in North Carolina and in the US. That's what we found in our sample also. The female proportion, not very surprising, 91%. White proportion, 85%. Patient falls, 3% of the nurses who we surveyed, they reported that yes, under their care in the last 14 days, there was a patient fall. 6% reported that they did make medication error. Now, obviously, these are very sensitive issues, and there can be potential for underreporting. And so one of the things we have been thinking about is use a different sampling strategy where you eliminate that field so that there is more accurate reporting. But Chris, when he did the cost analysis, he tried to adjust for the underreporting of these things. And I'll talk about that a little bit when I get to that particular slide. The self-reported quality of care on a scale of 0 to 10, the average was 8.4, and 7% of the nurses reported a quality of care score of less than 5. Depression, as measured by PHQ-9, 18.3% of the nurses, they reported a score of at least 10, which is, I guess, indicative of depression. And the prevalence was 5.3. The average score, depression score, was 5.3. Pain on a scale of 0 to 10, 70% they reported some pain, and 18.4% reported a pain score of more than 5. Average pain score was 2.5. Presenteeism, 61.6% reported a score of at least 1, so that there is some evidence of presenteeism. Basically, 61% of them are saying that yes, there was some loss of productivity because of our health issues. And 11% reported actually a bit more serious loss of productivity because of health reasons. This one?
So nurses come to work even when they're sick?
Now, one thing that we wanted to see was that how pain and depression are related to presenteeism. Now, on the x-axis, you see in the first figure, for example, pain. It's not the pain reading 1, 2, 3, 4, but we had highly skewed data, so we did a quartile split. So this 1, 2, 3, 4 represent the first pain group, the second, third, and fourth pain group. And one could see that, not just pictorially, but statistically, we found that there was a significant association between pain and presenteeism. And similarly for depression, we found the same thing. So the point is that these two things, they do actually contribute to presenteeism. Now here are some of the other findings. Well, one thing we did was that when we are looking at incidents of patient falls or medication errors, we had to use Poisson regression rather than the usual regression because these are very rare events. And we found that for each unit increment in the presenteeism score, the patient falls go up by about 18%, and same thing with medication errors. And these things will factor in the cost analysis. The quality of care score actually goes down by 0.15 corresponding to each increment of unit score in presenteeism. Now, this is the little difficult part, and I wish Chris were here. And maybe we'll talk about sort of crude numbers initially, and then, if need be, we can go deeper into how these numbers were created. For example, the loss due to productivity reduction. In North Carolina, it's measured to be 14,439 per nurse. Now, it's curious as to how did this number come about. And in the US, it's 15,541. And the reason for that is that for North Carolina and for the US in general, the total compensation, salary plus benefits, is a little different. For example, for North Carolina, the average salary, including benefits, is $88,582, and for the U.S. in general, including benefits, the average salary is $95,247. Now, I don't have independent confirmation on these numbers. I'm going by what Chris has put together. So basically, if you go by, let's say, the U.S. number, 95,000 is the salary, and there is the presenteeism. Actually, the prevalence of that is, the average presenteeism score is 0.163. So if you think of that as a 16% loss of productivity, that means out of the 95,000, 16% would be the loss. That's there because of that. And that's where this number, 15,541, comes about. And similarly, the number for North Carolina is 14,439. Then you multiply these numbers by the total number of nurses in the workforce. And again, I don't have information confirmation, but based on Chris's numbers, he says that there's about 1.5 million nurses all across U.S., and perhaps you know how accurate that would be, but multiply that with 1.5 million. And that gives you a loss of about 22 billion. Because of that loss of productivity, even though presenteeism average was very low, 0.163. But when you look at the total number of nurses, it adds up to quite a bit. And in North Carolina alone, the loss would be about 876 million. Now, this was the cost analysis was done in different ways. So this was one way of doing the cost analysis. Another was we also had measured the quality of care score, self-reported quality of care. Now, the average score there was 8.356, and by using our regression model, we found that the presenteeism was contributing, or if you could remove that, there will be, or because of the presenteeism, the quality of care would go down by a number 0.245, which sounds like very small. But then if you look at its impact, it turns out that it is about $2,800 per nurse for US and $2,575 per nurse in North Carolina. And once again, if you multiply that by the number of nurses that are there, so you would get the corresponding figures. So there is this cost factor directly because of presenteeism. Then there's also another way of looking at it which is through the reduction in quality of care due to presenteeism. But the most complicated was measuring the cost because of falls and medication errors. And again, Chris comes up with the number of $1,346 because of these two factors. Now, there are a lot of numbers which are going into this calculation. And once we agree to how that calculation was done, the rest of it is easy, because if that's what it is, then once again multiplying by the number of nurses that you have in the workforce, you can find out what the impact will be because of the falls and medication errors. Now, of course, the first cost impact is quite a bit, but then that's overall, loss because of loss of productivity. This last part is only based on medication errors and patient falls. And I think I can come back to this as to how some of these numbers were derived. But for now, let me hand it back to Susan.